Okay, let's get started. So welcome everybody and thank you for joining us for our second Public Health Palliative Care International webinar on evaluating compassionate communities, tension, participation, and power. I know from my time on the ground, evaluation was always something you were not super excited about doing, but I'm pretty sure obviously you're here, so you know that that is important for us. I'm just going to read you a little quick bio about Dr. Sallnow. She is a palliative medicine consultant with the Central Northwest London NHS Trust in London and an honorary senior clinical lecturer at the St. Christopher's Hospice and the University College London Mary Cure Palliative Care Research Department. That's a lot so far. Her PhD explored the impacts that can come from compassionate community projects, and she has published articles and book chapters exploring a new public health approach to end-of-life care. She has co-edited the book International Perspectives in Public Health and Palliative Care in 2001, and have supported the development of the international movement in the new public health approaches from the onset. She is a research lead for the Public Health and Palliative Care International and a vice chair of the UK chapter. A little bit busy. Okay, so I'm gonna just move on to our next slide. So just to recap, because there are, I know, some new faces here. So just to recap some of the new features for membership, because there are some people who had just purchased the webinar today as well. So we obviously are encouraging you, hopefully, to sign up for a membership with us, because 2 webinars cost more than a membership does. So we're hoping to get more members. So we have a new section if you've been exploring around on the phpci.info website. So there is a members only section now. And in that members only section is where you can find, for instance, Dr. Julian Abel's last webinar that we did in September. So you can see the recording as well as his PowerPoint, so you can access that. Contact list, so we're just getting permission from everybody to post the contact list of other members, so that way you're able to connect around the world, as well as the newsletter that we put out, I believe, 3 times a year. And yeah, so that's where you're going to be able to go in and see some of the member features that we're trying to create and keep going for you.
Bonnie, I think other people can't see the slides moving. We're still on the first slide.
Really? Because it says that I'm sharing. Okay.
And I think Chantal can't see the slides, so just to check.
Okay. I'm going to reshare again then. Zoom. Can everybody see that now?
Yes.
You can see it?
Yeah.
Okay.
Yes.
So the next one is obviously the newsletter. So again, that newsletter is in there. We will be putting it out, I do believe, 3 times a year. So you'll be able to read that. It'll be in a PDF form and you'll be able to download it and read at your leisure. We also want to just take the opportunity to remind everybody about the 6th Public Health Palliative Care International Conference that is in Australia. And abstracts are open if you would like to look at submitting some abstracts. And I believe registration's open now as well, my understanding from Carrie. And also the affiliation page. So if you are working on a compassionate community or compassionate city movement, we really do encourage you to get affiliated with the International Council. And you can simply go on to, you can see the address there, Public Health Palliative Care Info /cities, and you can either read what other cities or communities are doing so far to be affiliated, or you can also submit to so that your initiative become affiliated as well. And what's really nice about that is other people can see around the world the initiatives that are going on. And also, we just want to remind everybody we're really actively getting quite busy on social media, and that's where we're going to start pushing out a lot of our notifications as well. So we're not emailing members, you know, every other week. So here's our Facebook and our Twitter account, and we encourage you to like us so that, or follow us, so that you can stay up to date on the latest pieces that we're wanting to share out with everybody. So this is sort of how the webinar is going to go. Obviously, welcome remarks. We're going through that right now. Then Libby's going to take over and do a presentation for about an hour. And then there'll be question and answer. So the chat room, you'll be able to post your questions in there. Christina, you may see her in the chat room. She's another council member with us. So her and I are going to be managing the questions to make sure that Libby gets them when we get to that question period. On a whole, we won't be turning on the mics. It'll be done through you posting your answer or your questions, and then Libby, we'll be sharing them with Libby for her to be able to answer. Okay, so just in case you don't know where the chat room is, but there is a chat button at the bottom, and that's that bubble. And so you'll be able to click in there, and that's where you'll be able to leave your chats. I just wanted to go through it to make sure everybody knew where they could find it. So this is the chat room on the side. I'll be in there, Christina will be in there, and we'll be able to see your questions. All right, so I'm gonna stop sharing, Libby, and you,
Okay.
the floor is yours.
So if my slides don't advance, can you tell me, is that, or do a thumbs up, advancing? Great. Okay, so great to see so many people I know well here, and also some people I don't know well yet. So really thanks for joining, and I hope this is going to be a really useful kind of almost 90 minutes that we've got. I'm going to talk a bit about kind of evaluation in general, the kind of tensions and complexities that we see when we start looking at evaluating specifically new public health initiatives or compassionate community initiatives, because it is really fraught with these, and I think we need to be live to these issues before we even begin contemplating how to start undertaking an evaluation. Then I'll talk you through kind of an example, a worked example of my evaluation that I did of a compassionate communities project in London. And this just by way of giving an example, to illustrate how I did this. There were many meandering routes that I took around within this. So this is a kind of, it's almost a 7-year project. So I hope there's a lot of useful lessons and where I made mistakes and also where I found solutions. And then the final part is to really make it relevant for your settings, because that's kind of the whole point, that what transferable messages are there, what will you do in future, and how, you know, how can I help you with some of the questions. And I'd also like to learn a bit about how you have overcome different settings and different problems in different settings, because there's certainly no one size fits all to all of this. And so what I really want is for us to have a really good shared kind of discussion and understanding of these principles, and then how they may be implemented in different settings will be different depending on where you are. So now it has frozen. There we are. So we, before we kind of start looking at the specifics of how we evaluate, we have to kind of understand that we are entirely kind of context dependent. We're sitting within a strong historical context of end-of-life care, of evaluations, of community action. And a lot of that has prompted kind of where we are now. So the kind of movement away from top-down, kind of professionally led, professionally delivered health or social care interventions has kind of led to the development of the new public health approach and of compassionate communities movement. So that kind of historical context led to this new movement. And similarly, evaluation is prompted, it sits within a kind of historical context of kind of increasingly reflecting on the role of individuals actually who are affected by the evaluation, rather than it being imposed, rather than it coming from outside and being externally decided and externally delivered. There's an increasing sense throughout all research, throughout evaluation, alongside healthcare interventions, that actually we need to look at the people who are involved in the actual work and affected by its outcomes and involving them in. When we look to the future, there's issues obviously around the kind of sustainability of what health and social care can manage, and specifically end-of-life care, and also the appropriateness of what a public health a public health approach could offer in terms of health and social care, and the implications for an evaluation as well sit within that. What do we want evaluations to look like in the future, and what are going to be our capacity? So we kind of sit within this context, and it's important to understand where we've come from historically, what drivers are pushing for change, and what the needs are in the future, and how we're going to manage to meet those needs. And so from all of this really is this dominant narrative of participation. And this is really significant, way beyond obviously end-of-life care, way beyond healthcare and social care, through to schools, museums, government policies. Everything and everyone needs to demonstrate that they are consulting, engaging, collaborating, co-producing with the people with whom their service is aimed at or that they are serving. And so this dominant narrative is both exciting because it's the kind of crest of the wave with which the compassionate communities movement is surfing at the moment, and it gives us a great deal of kind of policy rhetoric, policy support to push these kind of movements through. But there's some real challenges with it, and whenever anything becomes a kind of dominant narrative within a society or even internationally, there's a risk that things start being used in tokenistic ways, that they're being used purely to apply some kind of gloss to a policy document, to a new strategic plan. And actually, unless we start really understanding what these principles are, then there's a danger of actually this almost being kind of a movement that doesn't lead to any real change. So it's not straightforward, and it's great that we've got such interest internationally and locally in participation, but I'm just going to talk through a couple of papers which really helped frame my thinking from quite early on around how we understand kind of community participation, and therefore how we understand the evaluation. So this is a paper that was published in 2001 by Lynn Morgan, and it relates to really kind of international development, so not end-of-life care, but focusing on what participation means. And it really helped form my thinking when I read this when I was working in the Neighbourhood Network and Palliative Care Project in Kerala in southern India in about 2003. And it had just come out around that time, and we were reading it with real interest because there wasn't much critical dialogue really that we could find at the time around participation. I'm sure, and subsequently there's been lots written, but it was a really key paper, and it kind of sets, the kind of distinction that participation is not a kind of homogenous entity. It's not a kind of one size, you just either do participation or you don't. Participation is determined by the kind of role you want it to play. Are you doing it simply to achieve a goal within a healthcare serving, or are you doing it as an end in itself to support participation and skills? And there's some really interesting ways that she conceptually divides it. And I think this kind of thinking is essential if we're then going to begin evaluating it, because we need to understand what component of participation we're looking at before we even begin trying to understand how to measure it. And then a more recent paper, which came out earlier this year by Glenn Robert and his team, and this focuses on a kind of UK and Australia perspective, but looking at this kind of zeitgeist, the idea that participation has become so universal as a concept, not even as a concept, as a word, I would say, being applied to everything, that it's in danger of losing its value, losing its meaning, because it's being used in so many different areas. And this one's open access, as you can see, so you can download it. It's in medical humanities. And they kind of look at some of the, more through the mental health literature, but some of the co-production and co-design projects they do, look specifically at some of the methodologies and how they've used them creatively, what's worked, what hasn't worked. But it's a really, the kind of intro of this is a really interesting reflection on what participation is meaning currently in kind of health and social care. So there are really good emerging critical dimensions, and I think these are absolutely essential to have before we begin thinking about formulating our research questions or our evaluation questions. And then finally, this is the diagram from a paper I did with a colleague, Sally Paul, about 3 years ago now. And this was really just trying to pull some of that critical thinking into a palliative care, end-of-life care context to say, well, participation isn't this homogenous kind of concept there as a whole, and it came from the ladder of participation, really saying, you know, right down from informing or just consulting, right up to empowering, and that there are different triggers that are going to move you along here. And it's not, this isn't a kind of judgment, kind of normative idea. It's not about what's better. It's about understanding where you are. You know, there are times that informing is really key. Some huge major public health projects have been on informing, giving information to people. But if you're using informing kind of methods, but you're looking at empowerment type of outcomes, then obviously you have a mismatch. So one of the key things then is understanding, okay, where is this project that we're doing? Where does it sit along this? So what kind of methods would be appropriate, and what kind of outcomes are the kind of outcomes that people could expect from this? So again, it's just a way of kind of slightly more critically understanding what we're actually trying to do in practice. And so there's quite an increasing critical research debate, which I think is really interesting. And I'm sure you have many other papers kind of locally, but also internationally that you'll know about, because this is being picked up in kind of diabetes work, in child health, in mental health, maternal health, etc. These kind of critical dialogues around participation. So I think it's worth kind of looking at some of the tensions that for me, I feel were live, certainly when I began looking at how to evaluate a compassionate communities project in kind of 2012. These were some of the issues that I was beginning to face and beginning to question. The first issue is actually in a lot of evaluating new public health or compassionate communities project, often there is no participation at all. It's something that funders do externally, or the service does externally, and quite surprisingly, many evaluations really have no participation to start with at all. And then there's the risk of tokenism, where you invite two users to sit on a steering group, and that kind of then gives you the kind of engagement that you need. Then looking at things like who sets the agenda, who's asking the questions, what kind of time frame are you setting? If a time frame is set as very short, then you're unlikely to capture a lot of the outcomes that we know are important. But if it's a funder setting a very short time frame for evaluation, then that's automatically going to exclude large proportions of different outcomes. Is it kind of reactive or proactive? Is it the community coming forward saying, look, we want to be part of this, this is our work, we need to be in the evaluation, or are people invited? And that's a very key distinction around kind of how people then feel they have the voice to participate, and where their influence is. Methods chosen are very important, because if you're looking at kind of statistical methods, often that requires a certain amount of knowledge and a certain amount of skill to do that you have to have been trained in. And so if you're looking at using those methods, then that is automatically going to skew who's going to be able to participate in those. There's issues of kind of voice privileging knowledge. Whose voice counts in this? Is it those who are running or paying for the evaluation? Is it those who are kind of running the projects? Is it those who are benefiting, or so to speak, from the project? You know, whose voice is it counts? And this is really important when we come to ask about what an outcome measure is that's appropriate. And then what's done with the results? Are they squirreled away within organisations, or are they sent in kind of behind paywalls to peer-reviewed journals, or are they locally disseminated and reports that are free? You know, what is done with the results? So all this really comes down to is, where does the power sit within this? Who is deciding? Who is allowed to decide? And who is deciding with this? So evaluating is really not a neutral topic. It's a highly political topic, and there's a lot of critical thought that needs to go in before embarking on it. So I thought we'd look at just 4 papers that give us a little flavour of kind of what the evidence is saying. Now, I'm using kind of evaluations that are published in kind of international peer-reviewed press, just because that's where it's slightly easier for me to get them, and often because local evaluations are not published internationally, often they're available just to those local organisations. So this is a kind of more examples of those published internationally, but there will be many more local examples, and you will know local examples from where you're working in. But this is to give you an example of what's being published kind of out there. So this is a really interesting paper that was published in the BMJ in 2008. It's not really specifically new public health. I mean, it's around befriending carers with dementia. So it's not a specific new public health project. It says it's very much a befriending project, which, as we know, kind of can sit either way in a traditional service kind of model or of a new public health model. But the way they described this is it was very much a kind of service delivery model. So befrienders were matched with a carer of someone who had dementia. They were very much not allowed to swap mobile numbers. It was a time-limited intervention. And the researchers decided, and there's no discussion of how they decided that really, but they decided that the outcome measures that were of interest were carer depression and carer quality of life. So carer depression and anxiety was one of the key things. They didn't look at outcomes for the befrienders or outcomes for the person with dementia. They focused specifically on that. And at the end of their intervention, which I think ran to kind of a certain number of weeks, quite a short intervention, they found no change at their primary outcome point, which was depression and anxiety, quality of life for the carers. So they conclude in their abstract that there is no evidence for befriending services in people who are caring for family members with dementia, which I think is quite a shocking conclusion to draw, from one study, but also to say that you are so confident that the outcome measures with which you chose, and who knows what those decisions are based on, are so rigorous and so represent the actual truth of what's happening and the actual kind of reality of what's happening within those befriender, carer, person living with dementia kind of environment. You're so confident that depression and anxiety are what really matters that you can say the entire project doesn't work. So this actually made me quite angry when I found this paper, and really led me to I think it really illustrates the power that we have by selecting these outcome measures. Firstly, politically, that makes it very difficult for befriending services or subsequent services to get funding. You know, it's hugely political, because if there's a big RCT saying, no, it doesn't make any difference, then it's very difficult to support funders, to encourage funders. But also, who decided that the specific carers were the only people who had potential to benefit from this intervention? That anxiety and depression is the key outcome we're looking at this. You know, who made those decisions? And by the researchers making these decisions, they come up with a paper, which I would say does not reflect my anecdotal experience in many other situations, but also doesn't really sit with the huge meta-analyses which support, you know, the idea of social networks not only have a huge impact on quality of life, but actually influence survival significantly. You know, so it doesn't sit with that. So the next paper was a paper in the UK from Catherine Walsh and the Lancaster team, the End of Life Social Action Project. And this was a big project looking at about 8 different either befriending or compassionate communities projects in the UK, which are already up and running. And it was a project, a waitlist randomized control trial. So people either had the intervention initially or had it 8 weeks later. And they were looking for, according to primary outcome measures, which were quality of life, social support, perceived loneliness. And so that's what the researchers decided to use for the primary outcome measures. Now, again, on the quantitative data, they didn't demonstrate any positive outcomes on any positive findings on the primary outcome measures. In the qualitative, they found a lot of different interesting themes and evidence of how this is working, how it wasn't working, and what the benefits were. But according to the quantitative data, they couldn't demonstrate any change. And again, one of the issues, which is, this is a really well conducted study, but one of the issues is that the outcomes were not what the people who actually were answering them, they said, this doesn't capture what I'm feeling. This isn't capturing the changes that I'm seeing in my own life. They weren't around quality of life. They weren't around health-related quality of life. They were around social connection, trust, meaning, and that didn't capture it in these tools. So again, it's a risk that the study seems to suggest that actually there wasn't a great benefit of the intervention. But what everyone's saying was there was huge benefit, but it's just according to these outcome measures, they weren't demonstrated. So again, it just shows you the power of what the outcome measures that we select when we're evaluating something. So this was a systematic review that I did in 2016. And after kind of casting it wide, looking at kind of about 4,000 titles and papers, I got down to 8 studies, which were 5 qualitative, 3 quantitative. And this evidenced that there were significant changes for the individual who was being cared for at the end of life. So, for example, increased likelihood of dying at home, increased support by palliative care services when you had a compassionate communities approach. Changes for the person who was doing the caring, or people, communities doing the caring. So the act of caring had implications for them and their lives, and there were outcomes suggestive around that. And then there was changes for the wider community. So when these acts of caring or these compassionate communities developed within a community, then that had impacts for that community more broadly itself. So these were small studies, and again, a mixture of quantitative and qualitative, but they, interestingly, I mapped the qualitative findings to a kind of conceptual map in there. And the quantitative findings, which tend to drill down onto 1 or 2 smaller details, could be mapped to that. So you could see how the qualitative had kind of gone broadly and looked at a range of different impacts that people and communities reported. And the quantitative figures, studies picked up on tiny parts of that and went down into more detail. So you could see how they were mapped. So this suggests that actually when we look maybe going beyond the kind of randomized control trial or specific quantitative outcomes, when you start looking more broadly, then actually you can start capturing some of these impacts. And this can be done in concert with quantitative measures, but you kind of need to have that idea of what are we actually looking for, who says what works, and then begin choosing those outcome measures that reflect kind of people's social and lived reality. And then the final important paper that's come out just earlier in October of this year by Julian Abel and colleagues in the British Journal of General Practice in October. I haven't put the reference on there actually with the day, so if you would like that, do let me know. But it's British General Practice, British Journal of General Practice in October this year. And what they're looking at, this is just an observational study, so there's no kind of causation that can be implied to this. But what they looked at was the Froome model, which is a general practice model of kind of social prescribing plus community engagement. And they looked at everyone who was discharged from hospital and who was looked after by Froome Medical Centre. And they, rather than just kind of waiting for the discharge summary, they got the person to come in, they mapped their local community networks, they looked at what was available and kind of embedded them in this kind of wider communities network of support, either their own support or voluntary organisation support. And their unplanned emergency admissions went down by 14%, whilst the rest of Somerset went up by 30%. So what the assertion is that if you engage people's local community networks and local voluntary organisations, then this has a big impact on people's utilisation of health services, but also their health. And so this again is getting at something else. There's something obviously here, and this doesn't demonstrate exactly what that is, but it's saying there's an association. between engaging with communities and so this and their health. And so there's another way of capturing that kind of data and getting at the kind of the crux of the point. You know, something is happening here. So I think when we look at how we reconcile all these findings, there are wildly different findings from really big, I'm sure, very rigorous and well conducted studies, but they're coming out with really wildly different results. And so this illustrates just how important it is to ground your evaluation in impacts that are actually meaningful for those, either participants, the service, the organisation, the community, but actually capture what's really happening. Because the risk of imposing outcome measures on the outside of either of what you wish that it was doing, or that you feel it should do, or the literature says it should do, doesn't necessarily reflect what's happening locally. So that's one of the key messages I'd like to try and impart. So when we start looking at evaluating something, I think there's a set of questions, and this is just an example of some of the questions that I was going through. There are many, many more. But some of the questions are around who is asking for this. Is this the funder who wants to take this evaluation back to demonstrate the value of their money that they've given to the project? And that is a very, very different evaluation to something that is trying to feed back to a local community to help them understand the impact of their work locally. So first of all, the question is, who's even asking for this? And evaluations, you can do a range of evaluations. It's important to acknowledge the different pressures that will be in there, because funders do obviously need evidence of where their money has gone and what that's for. But that kind of evaluation will look very different to one that's meant to support, encourage, motivate the local community for it to understand what it's done. So the first thing is understanding who's asking for this and how does that shape what we'd look at. Who's funded the evaluation, who's funded the project, and are we trying to kind of look at an outcome that is set by the local community, or really are these outcomes already set? Because often funders will send with them, when money is given, they will already have their outcome measures. So, you know, is it a done deal? And so we just need to evidence that, and then look at other more creative ways of evidencing other outcomes that we understand have happened. So that's one of the key questions. And then how much room is there for decisions on what outcomes matter? So if they're not set, then that's quite exciting. How could we begin looking at setting relevant outcomes locally? Another question is who measures them? Again, that's very politically loaded. Who's counting? Who's deciding what counts? And who's actually doing the actual measuring? Because who will be asking the questions, as we know, influences the type of answers that you would get. And what's the time frame? Because most kind of paid for evaluations, and people want quick answers. They don't want an answer in 3 years or 5 years at the end of your project. So the time frame will often impose serious limitations really on what you can try and capture. So I'm going to talk through an example now, which was my PhD, which was evaluating compassionate communities initiative called Compassionate Neighbours in hospice in London. So it's called Compassionate Neighbours. It started at a hospice in East London, and it's now running through 8 different hospices throughout the southeast of England. And the basic premise is that this is not a volunteering project in the traditional sense of what that means in kind of the UK hospice movement, because that's quite a loaded term. And so it's about people from the local community becoming compassionate neighbours. And the term compassionate neighbours was to really remove it from this idea of kind of the professionalisation of volunteers and people doing kind of tasks that are set by organisations. This was around being a neighbour in its non-healthcare, non-social care understanding. And the idea was that everyone knows how to be a good neighbour, whether or not they're actually embodying that and living that. It's a role that everyone is familiar with, theoretically or practically. And compassionate neighbours, because it's not just around death and dying and loss, it was about living. And so the idea was this was a term that was immediately accessible and understandable to people. So once people have signed up and want to become compassionate neighbours, they have a police check because they'll be matched with people in their own home. So that's the kind of the one formal part of it. And then they undertake a kind of peer led mentoring kind of training based on community development principles. And then they may be linked with people who live on their road or live locally, who are thought to be in the last years of life. And for other people, they go into more kind of community action, so kind of lobbying and raising the profile. Often people take the training and then go and just have their own matches locally in their own spare time. So there's a range of different kind of outcomes after people undertake the training. It was led by hospice at the beginning, which brings with it its own complexities, which we can talk about in how you begin evaluating it. And it was based on a community development model throughout. So this is my PhD, which was understanding the impact of a new public health approach to end-of-life care, mixed method study of a compassionate community. And my methods, and I think this is probably one of the largest parts and the hardest parts of the kind of 6 years doing this. And I got into some very, very kind of bleak places where I could not work out how to match the principles of a new public health approach with my need to deliver a rigorous study, how to give something that would hopefully be of benefit to the kind of the international wider movement on this, whilst also understanding and meeting the needs of those who are participating locally. You know, it was a huge kind of privilege. There was the funding supported that I really needed this to be something useful. So it was quite difficult to work out how to do this. And having come just from medicine healthcare, this is not something I had done a great deal of before. So I spent really years trying to work out this. But what I came to in the end, for better or worse, was that I really couldn't do an evaluation that was not congruent with the principles of the actual work I was trying to evaluate. So the ideas of participation, social justice, dissemination, being rooted in what's actually happening, so kind of the lived reality of those participating, those were the key outcomes. Those are the key principles, I mean. So once I decided that, actually things became a bit more straightforward, because I couldn't actually, you know, hand on heart say, I know what's going to happen from this project. And that was also quite liberating, because what was quite stressful is feeling I had to know what was going to happen when we started this project, which was then going to be locally determined by participants. And I had no idea what was going to happen. I had hopes and I'd read the literature, but I did not know what was going to happen in reality. So actually letting go of that was quite freeing. So we had an outlook that was flexible. So I could be open to different beneficiaries, different outcomes, unanticipated events. So rather than going in with a closed survey tool that would not capture any of this or allow for any changes, I decided to have open methods that would allow me to hear what was going on, understand and appreciate what was going on in many different guises, and then take this away and build really a conceptual map of what people were telling me, what I observed and what I understood to be happening. And this conceptual map, I hoped, would then be a kind of basis going forwards. So from that, you could then look at maybe using a survey tool for one specific component of that, or exploring something with a more specific methodology of one of those components. But at the beginning, I didn't feel able to select any survey tools that I thought could possibly capture the range of outcomes that were going to happen. So I did mixed methods. So I had lots of open participant observation, where I sat in through teaching, the training programs. I went through all of the meetings that they went to, the internal kind of hospice meetings. I went out on home visits. I watched them, went out on kind of community fundraising, community awareness events. So I sat through all of these to understand what was happening. I then did a series of interviews with a whole range of different people at home being cared for, compassionate neighbours going out, council members, other people involved in the kind of wider healthcare, social care area, hospice staff members, to understand what was really happening, and then documentary analysis and a series of focus groups. So it was really, really wide methods, because I wanted to ensure what my research was capturing was as good a snapshot of what people were really experiencing at that time. So I had ethical approval through the University of Edinburgh, where I was studying, and I acknowledged the role that I was a participant researcher. So I'd been involved in setting up the project, I'd been involved throughout, and obviously that needed me to acknowledge the kind of perspectives that I brought in with it. And so there was a large need throughout my whole work to reflect on that. And I used modified grounded theory, which allows you to really synthesize huge amounts of data, look at emergent themes. So as new themes were coming, I wasn't bringing them to it, but as new themes emerged through the data, I could then kind of create a new theory from that. So that was my aim, to kind of try and create a new theory and a new understanding from this data. So I collected data over 2 years, and this is an example of all the data. So I had a series of interviews with lots of different people, many of them longitudinal or sequential interviews, so I could go back and pick up on themes that they discussed and go back kind of 6 months or a year later and talk about how they had developed. Focus groups, and these were more towards the end as I took back my conceptual model and asked for them to kind of critique it to see whether it was actually resonating with their experiences, and got some really important feedback from that. Participant observation, where I just sat through, watched and asked questions and participated in a lot of the events. Documentary analysis, and then I had the kind of longitudinal data just of our compassionate neighbours and of the community members, of who had been referred, their kind of age, their demographics, why they've been referred in, what they were actually doing within it, to capture that broader understanding, so that the people I hadn't spoken to or directly observed, I had that data as well. So I could talk obviously for hours about those methods, but just to briefly come into the kind of the theme, so you could see what the outputs were. The 3 key themes were really, people spoke about personal transformation. So people really spoke about, this has changed my life in a different set of ways. So people spoke about the sense of connection, the sense that they were no longer either lonely or the fear of being lonely in the future had been met. They had meaning and purpose. There was a reason to get up in the morning. And so there was really strong stories of real personal change. But interestingly, and this is where it comes to kind of keeping an open idea of who your beneficiaries are, is that these changes were much more significant for the compassionate neighbours than for the community members, the people at the end of life at home. Now, I think it's probably not that much of a surprise for most of us working within compassionate communities work, but it certainly isn't something that's picked up significantly in the literature. And I mean, there's a big recognition of the change that volunteering projects can have, but really a lot of studies around this are not looking at just how beneficial it can be for the person essentially doing the intervention. So, and what was important was that there was a kind of, you could see a change. So when the community members, so people being visited at home, were more active in their relationship, so when they were able to take control, they started having some of these bigger, significant impact changes in their well-being and their loneliness. But when they were just quite passive and they were just having a visit once or twice a week from someone, compassionate neighbour, to come and see them, they didn't notice and they didn't remark or explain that this had particularly changed their lives. And what they were more interested in asking for was, they didn't really want, often, and not everyone, but a lot of people said, I don't really want another person just to come and sit in my room and for me to make them another cup of tea. And people spoke, particularly those who kind of had frailty, they spoke about this kind of limited amount of energy, and that they didn't have time to invest in something that really was one way, and people would just come and sit, but there was no long-term change and no change for them. And what they wanted was control. They wanted control over their lives. So there was some great, really interesting quotes saying, you know, from this one specific lady who said, I used to go to the library and I could choose the books I want. Now the library comes to me and they just give me books, you know. And obviously that's a great service. There is a community library able to give books, but she said, I'd almost prefer it not to be there. I don't want the books someone else chooses for me. I want to get my own books. And someone does the shopping for her, but she says, they bring the wrong fruit home. I don't want the fruit that they bring. I want to get my own fruit. And so this kind of sense, this isn't about just having anyone to come and turn up. And I think that's where some of the reflections about befriending projects can be. This needs to be an active relationship within which people feel they are in control and it meets their needs. And actually company was not really what people were always saying that they were specifically worried about. And I think it's cautionary with this big new dominant narrative of social isolation and loneliness is, you know, the biggest killer, and there's so much about that and there's so much truth within that. What we can't assume is the solution or the kind of the need for it is just for people to have more company. And maybe this is actually around how people can be engaged to be supported in their own active relationships. And we'll come on to this a bit more in the next slides. So the next important impact was that there was a new relationship between the community and the hospice. And this is not around service delivery. So the hospice is not saying this is another one of our services alongside inpatient care, community care, day therapies, etc. This is not kind of seen as another wing of that. This is seen as something very different, based on mutuality. And the hospice actually began listening to the impact, the reflections from Compassionate Neighbours, and changing its way it worked, its processes, and in a result of that. And it began inviting Compassionate Neighbours to speak on hospice's behalf at council events, to CQC, to other things. So there was a sense that they were actually engaging with them more like peers rather than staff members or people who were delivering a service on their behalf. There was a sense that actually they were working independently in the community. Not always, but this really began to come through. It was a strong theme. So it's based on mutuality rather than a service delivery model. And then finally, we began to see how people involved in this project, mainly Compassionate Neighbours, but others too, began expressing this beyond the confines of the project. So we began to get this kind of social ecological change where people were saying, yeah, I've begun reflecting on actually what my role is in my own street, in my own church, in my own mosque, in my own school. You know, what am I doing actually to embody these principles? So beyond that kind of match, which may or may not have been a key part of them joining, people were saying this has changed my whole understanding of what this means to me. And I certainly feel, even evaluating this led to me reflecting on what am I doing on my road locally and, you know, my street, in my community. And I think that's the idea of this. This work isn't limited to people who sign up to be trained. This is a part of a compassionate community in its broadest sense, and of which we are all participants, whether we are working from organisations, as people being trained, or etc. So there was a sense that it was changing the whole kind of social ecological context within which it was embedded. So these are the key impacts that I found. But the question then was, well, what is behind these? You know, what is influencing these? These are the ones that were very clear. People came and told me this. I observed these impacts very clearly. What was leading to those changes? And that's what I wanted to kind of go to a deeper level to understand what the processes were. And so the four kind of processes really were, the first, that the training that was being delivered builds networks rather than people coming to be trained to learn a new role. So this wasn't kind of, come to training, learn how to be a compassionate neighbour. The premise was you already know how to be a compassionate neighbour, but you're here obviously because you want to either understand more about it, become a better one, learn about other people. So it was very much based on, we already know how to do that, but there are barriers that stop us doing it in everyday life. How can we come and learn about that? And that might be people's personal previous bereavements. There's a lot of working through of issues that people have brought with them, kind of fear of knowing how to, you know, begin conversations, knock on people's doors, and then also the kind of fear of the process. Will you get in trouble? What gives you that kind of right to knock on someone else's door? So lots of talking around that. The relationships were both the process and the outcome. So the outcomes were facilitated by these relationships that developed throughout the project, but they were the process, actually building relationships, develop people's confidence, develop people's connection. So they were seen as both the process and the outcome. And here, so I kind of said community member, and in italics, I've kind of given what the funders, or the kind of the traditional way of understanding them. So the community member in the funding bids was all meant to be kind of the recipient. The compassionate neighbour was meant to be kind of the intervention, and the hospice was the funder. But actually what happened, and normally these three people or kind of processes are set very separately within an evaluation. But what I understood was that actually there'd been a subtle changing in the relationship between all of these, and the boundaries were blurred. And actually the community member and the compassionate neighbour, there was no sense of someone coming to deliver an intervention to another. There was a sense of peers saying, and one of the quotes was from a compassionate neighbour, I'm on this side of the door today, but I don't know when the change is going to happen. And the sense that just because I'm on this day knocking on the door to someone, I don't know when someone's going to need to come and knock on my door to support me. And actually what we saw throughout the project change was compassionate neighbours becoming carers, becoming ill themselves or becoming bereaved. Community members, we had many patients who were then training to become compassionate neighbours. So they were then supporting people within their own community. And so that took some arguing with the hospice, because there are some rules around whether patients can become volunteers. And so that's where then the community began pressurizing the hospital, saying, well, this is unacceptable. We need to be as able to give care as much as we are to receive care. So there was a sense that these relationships were based much more on equity than your kind of traditional service type relationships. And the boundaries were really blurred. So people moved between community member and compassionate neighbour. And these equitable relationships allowed reciprocity to begin. So people could act reciprocally. They could give and also receive. And that was the whole kind of point of these relationships, where they were meant to be authentic relationships. So actually people went and they gave either company or advice or support, and they received that at the same time. And that was okay. That was part of the whole design of the project. So behind this, really, going one step further, was what were the real underlying principles that I could understand. And after being kind of really embedded in this data for so long, I could really see there were three key things. The first was that power was being changed and shifted. And that was the really underlying principle. So the hospice was able to say, fine, we understand actually some of our processes, the way we're acting, the way we're running things is quite inhibitory for these kind of works. It's excluding, and we need to change them. And there was enough power shifted within the organisation, within the community, to say, let's make this happen. And that did happen. And that also happened between the community member and the compassionate neighbour. There was enough power shifting within it to say, the compassionate neighbour didn't turn up and say, I've got the solution to your loneliness. It's going to be a cup of tea with me every week. There was no sense of that. But there was a sense of, look, we are all in this community together. We live on the same street or in the same area. What can we do together to help each other? And so that allowed reciprocity. So people were each contributing within that relationship. They were not one-way, passive relationships. They were two-way. And once people begin acting reciprocally, so that they are able to kind of begin influencing their environment, the other people who live among them, etc., and their own outcomes, then people begin feeling they have agency, because actually what they do changes outcomes, either their own or others. So these three key things were what I understood to influence and make compassionate neighbours work in the context that I was looking at. And so there's two models now, just to say that this is the kind of the final outputs of my PhD. And I kind of quite like things to be simple, and for there to be kind of something on a page that people can take away and say, yes, this is what I understand this. So this page and the next page are my kind of two key outputs, which you can see on 2 pages, which help explain the whole PhD. And this is collective social capital, which is a new name that I used to describe what I had seen. And over here, first of all, is kind of traditional social capital. So you've got these 3 levels in social capital, and some of you might be familiar, I'm sure, with this. So you've got bonding, which is basically between people are the same. So families going to the same school, supporting each other, and these are friendships or within the same faith community. So you're united by something that makes you the same, and you're not operating across kind of power differentials or difference. You're broadly similar, and you're acting to support each other, and you have these kind of two-way reciprocal relationships, and that's illustrated here as with these kind of similar communities. Then you've got bridging, and that is across people who are different. So it might be from different faith communities, getting to know each other, different local organisations who are different, but are operating not really across any power differentials or anything. They're just beginning to support each other. And that's really crucial for social change, and kind of leverage, because you can start using resources and building on resources from groups who are different to yours, who may have different assets and different strengths. Some of the key things is trying to build these connections between communities, so they can then start leveraging all each other's assets and start building their own social capital across difference. So that's bonding and bridging. And then linking is illustrated here. And in the literature, it's really described as a kind of one way. There's not much written about it, but it's basically where communities, organisations, individuals try to link with the services or the institutions that serve them. So hospitals, police stations, government, general practice surgeries. So it's how they begin operating across this explicit power differential, because there is explicit power within that. And they're often seen as one way. So consultations come out, people can try and influence and kind of lobby to have services change, but they're generally not seen as a kind of equitable, collaborative approach. But what we saw here, and in this case, this is the example of the compassionate communities for the hospice, is that because the power was changed, and we can talk more later if you want about how that actually did change, but because the power was shifted sufficiently that the hospice was willing to change some of the way it was acting and change some of the practices that it was doing. And then the community also was looking at, well, how can we develop our own capacity and what could we feed back? And there was this reciprocal relationship where there was two-way dialogue and two-way change in both ways. And so this leads to a totally different type of relationship than here. And so I called it collective social capital, to try and capture what is happening when an organisation is developing its own capacity and looking kind of critically at its own practices alongside when a community is doing it. Because the new public health approach is all about obviously developing community capacity, community resilience, but to not include the organisations specifically around end-of-life care essential, but all organisations that support that, is quite one-sided. You know, we need to be looking at developing the resilience, the capacity, and the ability to reflect critically across the entire community, within which GP surgeries, schools, etc. need to be included. So it's a kind of much more reflexive, critical model within which all community players are involved, and we need power dynamics to be shifted across all and allow reciprocal relationships across all players, not just those within the community. And then this is the final thing, which we don't need to go into big detail, but this is the kind of my PhD on one page, which puts together all of the different kind of outcome processes and outcomes that I found. So people engaging as peers, so that power differential being challenged, allowing people to come in as peers through this universal issue, which interestingly was sometimes death and dying, but was often more often than not compassion and expressing care to live with people who live near to you. Then the new space that was created by the project allowed these reciprocal relationships. That led to new networks. The new networks led to these new ideas of social capital, both bridging and collective. And then a new ownership of the hospice by the community, and this sense of agency that developed, and then that leads to the impacts, and then all of that feeds back again and again. So this was kind of really what was happening that I could understand through my evaluation. So come on to the last part now of the discussion, really looking more generally now, because that was one example of how I chose to embark on an evaluation. But just talking more generally about what's practical, what's useful to get people started or to develop people's evaluation. So one of the things I think is helpful is, and some of you may be familiar with Alan Kelleher's Big 7 checklist. And this is really old now, it comes back from kind of the 90s, late 90s. But it was really Alan's idea of trying to make people think at the beginning, what is your project really doing? How is it actually a new public health approach? Are you just doing another service but calling it a different name? So how do you think critically at the beginning, and then how do you evaluate? So you've got to be able to answer one of the first three. So how does the activity actually prevent social difficulties around death, dying, loss or care? So it has to be either trying to actually prevent them even from happening, so a real upstream public health approach. How does the activity or initiative minimize the harm? So it's already happening, but trying to reduce its intensity and trying to make it, the experience of it less difficult. Or is it an early intervention? And so basically these are, using kind of prevention, harm minimization and early intervention. These are kind of public health ideas. So not crisis management, basically, not waiting till it's already happened and you're just trying to pick up the pieces. Actually, how is this a real public health upstream intervention, according to one of these? So it's got to be one of those. And then all of the following four, which is, what way does it change the environment or setting for the better? What way is it participatory? Is it sustainable? And then can you evaluate it? And so these are the key things that you need to be looking at. Obviously evaluation is part, but evaluation, I'd say, is all of this. And so being really clear from the beginning in what you're trying to achieve and actually being honest. And it may not hit all of these in significant ways, but there will be ways in which it's changing the environment, and it will need to be participatory by default. It has to be sustainable, otherwise it is a service. If there is no sustainability, no matter how much you think it might be, it is just a service. It has to be sustainable, and that might not be in the medium to long, it may not be in the first few years, but there has to be an understanding that this eventually will become sustainable. And then evaluation is crucial. So really, this is I think my penultimate slide now, really. But and this is why I hope we could open it up for some discussion. But I would say my kind of reflections on having done this specific bit of work is there are so many amazing examples of how to evaluate kind of community action, social action, community development, participatory work. Internationally, there is a real wealth of this, but there will also be some around the corner. So one of our most valuable contacts that we made was a community development charity, like a health advocacy charity, who worked on the road next to us at the hospice, who were doing lots of peer support work with minority groups, with peer workers who spoke local languages and were trained entirely in community development. And they were doing work around mental health, maternal support, diabetes and weight reduction. They knew nothing about end-of-life care, but they were really, really radical in their understanding of kind of people-powered health and the role of advocacy and supporting people to make their own decisions. So we joined with them, and they we had a very fruitful, really uncomfortable at times relationship with them, where they held a mirror up really to what we were doing. So some of the volunteering practices, which was, you know, the training runs 9 to 5 every day, Monday to Friday. And they just said, but look at who cannot possibly attend that. People who are trying to work, people who are picking children up from school, people who are trying to care for people. So they just said, if you, I mean, that was one tiny example, but, you know, if you continue doing this, then you're just going to have another befriending model, another volunteer service model. So unless you change it, you will not get new people coming in. So that they constantly questioned everything we did when we were starting to set up the project. And it was so valuable. It led to real tensions and a lot of very difficult discussions. But this project would not have been what it is if we hadn't had that. So having a kind of critical friend who maybe has got full experience of doing something differently, it may be nothing to do with end-of-life care, but these principles are so transferable, it doesn't matter. You know, you can easily learn the specifics of caring for those at the end of life in this particular area, but the principles that are really difficult to learn if you don't have them already are the ones around participation, how you share power, how you begin bringing social justice into this kind of project. And community development and health promotion have been doing this for many years, since the 60s. So there is a really significant wealth. And I went right back and read through a lot of the kind of early HIV community interventions kind of in the 80s and 90s, looking at trying how health promotion was trying to reduce spread then, some of the kind of cardiac, like heart health projects, kind of the seatbelt stuff, all of those kind of different projects, how kind of different public health projects managed to evaluate their impact. So I went back and looked through all of those. There's some really helpful things. I mean, the literature is big, but it's really worth looking at. Then I would think really creatively. And I think the risk is that everyone just thinks of surveys because they're quite straightforward. You can get a validated one off the shelf. You know, there are surveys for almost anything. But I would think, unless you're really, really clear with what impacts you think you're finding, and people have said to you, this is what we want to understand, who the people actually who really feel this is the experience, then you can find one on connection, on social networks or something, and then do use it. But before reaching for that, I would think about different ways, and I would really think of mixed methods. You know, don't just stick with one method, because you're unlikely to get, you know, the light that shines is just going to be one small patch, whereas if you manage to get different methods, you're much more likely to see different things. And I certainly found when I was using the many different methods in my study, that each time I was getting something slightly different, then I could take back to the interviews and say, look, you know, I've noticed this, or people are saying this, what does this mean to you? And actually people often hadn't quite realized that, or we began discussing something that they weren't fully aware of. So each method shines a different light. But things like impact stories, so what has really been the biggest thing for you, and having a narrative of participants explaining what has been really significant, and that can be really powerful to sit alongside quantitative data, but it really illuminates what's happening. Community-based participatory research or action research within that. So thinking about how you can train and support community members to actually go and do the research themselves, even, you know, hopefully set the agenda, decide what the outcomes are, collect the data themselves. So That requires often some training. I mean, CBPR is a full kind of methodology, but there's different ways that you can include all of this stuff in work. And we're certainly including lots more community researchers in almost all of our bids at the moment. And they're at the moment out collecting data, and it's been hugely rich and really, really interesting. Things like photo voice, where you're actually giving people cameras and they're capturing pictures of what actually is happening. So it doesn't have to be words, it doesn't have to be numbers, you can actually get images. Most significant change methodology, which is a specific method, which you can, if you Google, you can see the detail on that. But I've got some good colleagues in Sweden who are using this with their public health examples to capture what is the significant thing that really changes within your project. Quality improvement methodology, you know, it doesn't have to be research. There's a big, enormous international repository of information on how you do quality improvement. Your PDSA cycle, just, you know, test something, quickly innovate, change something new. And this is much more in a kind of, you know, the innovation fields as well. Doing research is really, it takes a long, long time. So if you can do something much faster, the turnaround time is much faster in kind of innovation and quality improvement. So it may be that this is much more important. And as long as you're capturing data along the way, it can be just as useful for funders or for local dissemination. And then there's the kind of complex intervention frameworks, which if you're looking for a kind of bigger piece of work, that gives you support with how you begin understanding the theory of what's happening underneath in your intervention, and then how you begin capturing parts of it. So in summary, new public health and compassionate communities projects are not services. And so that's the thing, they're not interventions that can be just standardized and delivered, which means measurement is really, really difficult, inherently complex. And I would say a lot of the stumbling blocks that other studies have found is that they have assumed they are standardizable, that the same person coming to visit you at home is going to lead to the same outcomes. And in reality, the outcomes are so different depending on that relationship, depending on what's happened, depending on you. So you can't standardize, and that just has to be accepted from the beginning. The beneficiaries or outcomes might not be at all what we expect from the beginning. So you have to use participatory methods to include people, because otherwise these assumptions just get borne out and the study doesn't demonstrate anything. And the work must really be congruent with the principles of what we're trying to understand. It can't be completely different. You know, if you're running a participatory new public health compassionate communities project, but your evaluation is a kind of helicoptered in RCT by a team of researchers who have nothing to do with the work and don't appreciate that, then it's not going to work. Timeframes are really important because impacts don't come for a number of years sometimes, so that's important to bear in mind. The best methods to capture change might not be the traditional ones, so just don't always look necessarily for surveys, and look for some of these different models. But you do need to be clear. If you're looking for proving to the funder that the money they gave has been helpful, then you may need to use the kind of methods that will speak to them. So you do need to be strategic. If you're looking for trying to demonstrate that the number of matches they had, that they funded, then it may just be quantitative numbers. Capturing that and feeding that back is going to be what's most helpful. So look at who your audience is and what they need to know. Power is central for all of this, and I don't think we really ever acknowledge that within healthcare. But evaluation is hugely political, and power is central throughout that, as it runs through as a key theme throughout all compassionate communities projects. And really, communities, organisations, researchers, everyone in it need to reflect on their role, their position, the power they hold critically. And I think that's not done often enough. And we, in our experience, were forced to do that. It was very uncomfortable, but it was incredibly helpful. And I think that's what we need to support. So finding a critical friend who can hold that mirror up and just question, but why would you do that? Why are you doing that? Why not do it this way? Is really one of the most important, I think, points going forward, both running a project, but also when you're trying to do that evaluation. Okay, that is me finished. So I'll hand back over to Bonnie.
Can you see my screen, Libby?
Yes.
Okay. I'm hoping everybody else can as well. Just quickly, I wanted to share, because I think my slides were not being shown earlier today. So just to remind everybody about the abstracts are open for the international conference. and, you know, the idea of becoming affiliated. So this is New Westminster, a project in Canada that just recently became affiliated as well. And the links to our social media. So because we're going, like I mentioned earlier, be pushing people to go there more often to see the latest stuff that's going on and advertising our webinars and things like that. All right, so off to the question period. So we did have a few questions that have come through already. I'm just going to open my chat room again. So one of the questions that was asked by Greg was, what organizational strategies did you use to coordinate compassionate communities?
Okay, so what organizational strategies? Could I ask Greg, could he be unmuted maybe, just to kind of, what does he mean by that?
Okay, just a sec. I'm just gonna so just to let everybody know, you're all unmuted now. Just
oh dear.
Hello everyone. Hi Greg.
Hi Libby. I think the question, the way I originally wrote it, was what organization, well, there's a lot of background noise. What organizational strategies did you use to allow in compassionate neighbors in the program you already have going? How do the compassionate neighbors interact with one another? And what is there a strategy, an organizational strategy that you set up to allow the coordination of interacting
I've got that. Okay, I'll let you mute us, Bonnie, so we can all hear you.
Yep.
Yeah. Really guided by the community development methodology. So rather than kind of looking at training, oh, can you hear me?
Yeah, I can hear you.
Sorry, I seemed to say I was muted. So rather than kind of looking at recruiting people, training them in a particular way, and then having a kind of case review every month that they could bring difficult questions to, the whole focus was on peer network development. So the training was, it wasn't didactic, it wasn't about PowerPoint, it wasn't learning kind of confidentiality, safeguarding, all of those kind of things. It was loads of network building. The community development team called it kind of lots of inside, lots of outside work. So lots of kind of understanding where you sit within this framework, or where you feel you are, and what you're comfortable with, what you're not comfortable with, and then understanding that other people have different ideas, and that's also fine. So what they, one of the exercises in the training that I've sat through many times, which was really helpful, I think probably illustrates this, is they would have a big room and get everyone in the middle, kind of 20 people taking part in the training, put them all in the middle of the room and say, so we're going to ask a series of questions, and what you've got to decide is what's right for you. So in your person that you're going to be matched up with, would you be happy to share your mobile phone number with them? Everyone who feels yes, definitely, right over on that side. Everything who feels no, absolutely no way, on that side. And everyone who kind of feels in the middle, it would depend on who they were, depend on kind of how confident I felt, how well I knew them, in the middle. And so the room would just be split, obviously, with people, right the way through. And then there were other things like you walk into a house and there's washing up piled high in the sink. Are you going to start doing it? Or are you not going to do it? So you're not going to touch it with a barge pole. And then again, people are kind of completely split. And then, discussions like, well, I would want to kind of know how that person felt. Maybe they needed me to do it. And other people would say, no, what an intrusion. We're not there to do things. We're there to. So, there was that kind of training was what the main thing was. It was saying there are not loads of hard and fast rules. There's some rules which are around, you must not give people medication and you mustn't take money, really key things. But it was all rooted back, not in a kind of professionalized context, in a kind of, if you were caring for a neighbor, would you take their credit card out and start getting money out if they asked you to? Well, most likely not, but if you knew them really well. But, the idea was that's a rule not to. You would not do that and you wouldn't be giving them medication. But you would make a cup of tea if they felt that. Or if they said, would you like to go out for a walk to the park? And yeah, you think about going out to do that. So it's about how you personally set your own kind of your own comfort, understanding that also the person who you're visiting is their own individual. They have their ability to set their own level of comfort and what they want. So it was this kind of sense of it being a negotiated relationship. But for most befriending services, stuff happens underground anyway. So people swap numbers, people do things, but they just don't ever own up to it if it's not allowed in the kind of in the manual. So the kind of organizational framework was very much not the hospice volunteering model, which was very kind of traditional, but based on this community development framework. But interestingly, when I was saying about how the project began influencing the hospice, the volunteering department began changing in response to how the Compassionate Communities project was developing. And they then began changing how their kind of recruitment was doing, what their training was doing, how they were looking at supporting volunteers themselves. So that began having this kind of bigger impact on the hospice more widely. So it actually changed their strategic kind of line. I don't know if that answered you. Let me see the other bit of your question. And so a lot of how they communicate effectively. So the Compassionate Neighbours would have WhatsApp groups. They have the training is over 4 weeks, or it's 4 days, either 2 double weekends, evenings, or in the day. Then every month there's a kind of big collective group, a kind of private group where the Compassionate Neighbours come back in, share. It's about self-reflection, not just casework. It's about them developing themselves. And then every week there's a coffee morning held in the kind of big open space in the hospice where people come. There's kind of learning. They learn about kind of fuel poverty, different things that, you know, would be helpful for a community to know about. And then a lot of them have informal meetings, just people become friends, and there are these WhatsApp groups, so people will have kind of their own network within that. And the privacy concerns, people would, so you'd have a DBS at the beginning, and there was confidentiality. So it wasn't, and it was spoken about in confidentiality in terms of that formal term, but also, again, in the same way, it was saying what's appropriate to share and what's not appropriate to share. Like, if someone tells you something very personal, is it appropriate to share it on the corner of the street? You know, how do you think about it? So it's more about kind of, like you say, privacy than this kind of slightly more professional confidentiality. And it was very minimal information that was being shared. So people could decide to share their own information and then talk about what they felt like sharing and how they would then keep that personally. So I'll have a look at some of these next questions.
Yeah, Mary Lou Kelly has a couple of questions around evaluation.
Okay, so how long, so I collected data, well, officially I collected the data for 2 years, but unofficially, you know, before I had ethical approval, I was part of the project. So I was already thinking in my head critically about what was going on, but I collected it over 2 years. And so that had big impact for the kind of long-term impact, long-term collection of data, because a lot of the stuff, the project took so much longer to start than we thought it would do. So there was no data actually to collect until at least 1.5 years really later than I'd thought. So luckily we had really flexible timeframes, partly because I had a baby. So I suddenly added an entire year on to the time, which was really helpful, because actually we really couldn't collect anything early on. And that's one of the first things. Don't set your evaluation up too early, because people haven't even been matched and there's no outcomes you can look at. So we had the participant observation and the interviews were from the beginning, and then it continued on. So I went back to the same people kind of 6 months later and asked them what had changed, and we went back on some of the themes to expand upon them. I think if I'd done it again, actually what I would have done is probably, now I know in hindsight, the training really represented a community development intervention in itself. It was, many people didn't come back and get matched, they just learned and went away. And the impact that I could have captured just from the beginning and the end of the training was so significant, that would have been something in itself. So that would have been a great first short-term outcome, a quick win I could have got. And you could have actually done interviews or even used a survey if you knew what actual kind of outcomes people coming to. So I could have captured something quite quickly then, but the other ones, the longer term impacts needed, because it was looking at the impact of a relationship, those relationships needed to kind of mature and people needed to get to know each other well. So yeah, I kind of had a range of short to long term impacts. So let me see.
So Caroline Morgan has a question.
Okay, just going to say hi to Mark from Woodley Farm. I wondered who that was at Woodley Farm, so welcome, Mark. So Caroline, so there's lots of different groups using compassionate community approach. Yeah, so I think this is one of my kind of issues. I think that's why I made that first kind of spectrum, just so that people could understand, where they all sit. And I think it's a bit like the participation issue. People just want to use the term compassionate communities, often with really good intentions, sometimes not so much, but if maybe you're not really doing this. And I think my general sense is of inclusivity, because I think we need for this to be a social movement, then we need to include everyone. Absolutely everyone needs to be involved in this. This can't be a few isolated examples throughout different kind of hospices or different areas at doing it. So we need to include everyone. But I just think everyone needs to use the language appropriately, so be clear with what they're doing. So Compassionate Communities Initiative have a few things at their core. They are participatory, they are not services, they're not kind of service interventions. They have to be done with people, and they can't be led exclusively by an institution or an organisation. It has to have some local ownership, leadership. At the beginning, often it's a bit less balanced, because ideally you'd have a community knocking on the door of a hospice saying, excuse me, what are you doing about our end of life care according to our needs? We've decided this, come and support us, do this stuff, but we're in charge, ideally. But a lot of the community members who I was talking to are overwhelmed with surviving, with other issues that are happening, and they're not, for whatever reason, knocking on doors saying, listen, take our end of life care more seriously. So then you kind of have the role of needing a kind of organisation, like a catalyst to start it, and often that's around some funding, having someone who can be a community development advisor to kind of start something. But then you have to know when to step back, because the danger is after that first kind of catalyst, you then need to move back, otherwise it turns into a kind of a service that's being delivered by the hospice, and that is an incredibly difficult area. But I would say we need to be generous and support and help people understand if they're using a term, but maybe it's something that isn't embodying the principles of compassionate communities, then point them in the direction of something to read, of some of the papers that are out there, invite them along to other projects, kind of say, look, this is kind of the principles we're trying to embody. How could we begin to support you to do that? Because I think we do need to help, rather than being punitive, help people to realign and understand what they're doing. But it's a real risk, and certainly when we've done some of our bigger studies nationally, people are using the term for running a community palliative care clinical service, like that obviously isn't. So it's difficult.
So Mark has a question, if you can see it there.
I've got Hospice of Isle of Man. How would I evaluate the training? That's really interesting. So I think I'd only probably evaluate it after I had sat through, spoken to, observed, understood what people found the impacts were. Because at the beginning, I would not have understood what the impacts of the training were until I'd sat through it, if you see what I mean. So I don't think you can do it at the beginning. You almost need to actually run it a few times over before you can begin understanding. I mean, I think the key thing is interviews and focus groups. Just, you could almost have the last session saying, what have we learnt? Is it okay if we record this? And then pull out the themes from that. And then the subsequent, now the training that we'd run, it would all be around network development. Tell us what networks, what relationships you've had. How has this network changed your experiences of, people were talking about, I'm now bought a mobile phone. I have a reason to get up in the morning. I have people to call. I have things to do. I'm needed. That is not really end of life kind of the key outcomes that you'd be looking for, when the funders who funded us initially were all about the matched visits and the outcomes for the people at the end of life. So the problem is demonstrating those kind of outcomes is they seem so far removed from kind of end of life outcomes. But actually, people were talking about their own advanced care planning, their family members, which is at end of life. So you would start seeing changes after training. And what would be really exciting is then to follow them up and say, how does this change your end of life? But you'd need a study that would be, from like 1 to 40 years long, potentially, to capture all of that. But that's where I think you'd start seeing real changes, because people are thinking about what end of life means, thinking about advanced care planning, not using those terms at all, but just thinking about actually what is important for me and why do I need a network? How can I make sure I've got people around to support me? Now I understand how important a network is in quality of life, in quality of death, in living, everything like that. So I think networks are the key really for picking up the change for people doing this. And at the end of life, it was those people being visited at home, as I said in the thing, they weren't really so interested in company, just for company's sake. They wanted control. They wanted to be able to manage their own life and be in charge of what was happening. And they were sitting passively waiting for carers, waiting for people to give them stuff, and they wanted control. So I think that's something we really need to think about when we're looking at loneliness interventions. I think it's really sobering to think that.
Okay, Libby, I'm just going to read you out the questions just because I've been writing them down. So Mark asked the question, how, so he's been working on a project for 18 months. His question is it time to evaluate?
So I would say if you've got some people who are coming forward and saying, this is the kind of change that we're seeing. If you've got people saying like, this has changed my experiences, my life in whatever way, then I would say yes. We probably began evaluating after about a year. It took even longer, probably kind of 2 years in was when I started properly collecting data. But I would develop, if you've got good relationships with the people who are involved, if you have started, you could do some focus groups before, just to start understanding what changes, what's the most significant change for you, what impacts are you seeing? And then you could start doing focus groups, which would be really, really straightforward. And then it depends whether you then want to kind of have something more quantitative as well, because then from the focus groups, you could work out what are the key changes, map all the key changes that people are saying. And then if you want to use a survey tool, find one that measures those outcomes, captures those outcomes, and then you could use that more broadly. It depends how many people are involved. If it's small enough to interview or have focus groups with everyone, that might be the best way to start it, but knowing you could then use that after. Okay.
So Pam has a question. She said, could you comment on using social network analysis as a way of showing network enhancement across the project?
I think it's so exciting. And social network analysis, I would have to defer to Kerry Noonan, Rosemary Leonard, and Debbie Horsfeld over in Australia. They are doing all the work on that. I think it's really useful if you want to capture something quantitatively. And I'm increasingly looking at social network analysis. So it's not my kind of full expertise at the moment. I'm definitely going to look more into it. But I would look at the work that Kerry Noonan has done on that, because they've written quite a few papers, certainly one big one on it. And I think it's a really good way. So you can either just use it kind of pictorially, so you do it on big flip chart papers before and after, and just count up yourself, or you can use the formal technique, the quantitative technique of social network analysis. So you could do it just by yourselves by counting, or you can use that. But either way, I think it's a really valuable methodology, definitely.
So the hospice, Isle of Man, does the perception of what people want to get out change as well?
Yes. So a lot of people turned up to do the training as a kind of, I want to help other people, I kind of want to support other people. And actually what often came out after was, so the compassionate neighbour saying, I now have a social network, I'm now less lonely, I didn't think this would change me, I came into it to support other people, but actually what I've noticed is my own life has changed so much. And I think that's what's really interesting. So people often don't realise the power of what they're going to join when they suddenly have this strong network and they're doing things they thought they would kind of just be matched up with one person at home visiting them, whereas actually they developed a kind of new network around them, which was unanticipated. And really significant in their lives. So definitely the impact change from what they thought they'd get when they first came in to what they did actually get.
So another question by the hospice, what do you think about measuring mental health benefit to volunteers using a scale pre and post?
Yeah, I mean, I think it depends kind of, again, I would not just go in with a tool like that before speaking with volunteers or compassionate neighbours or whoever's doing it about what their motivations are for joining, what their current feelings are, and then what they have felt after they got out of it. I wouldn't go in straight with a tool. I'd speak to people first to understand what they say the impacts are. And if they're really around mental health or anxiety, then follow that up, but don't kind of assume that would be. I would speak with them first. Let a couple of people go through to understand what the meaningful outcomes are. But, things like death literacy scales, death anxiety, those kind of things can be really useful. but you just don't know what the people who sign up are actually going to be in it for or will benefit. That's an assumption, and that's just what I would query. Actually check with your local people who are actually saying this is what's happening for me, and go be based on that, and then find a measurement tool that captures that kind of rather than the other way around, because otherwise you risk not capturing anything and undermining kind of what the project seems like it's about.
So one other question from Greg: how receptive are community members to the compassionate neighbors concept?
So hugely, I think really, really interested. There was a bit of kind of, I would say, befriending fatigue, where people had just people turning up all the time in their homes, and what they wanted to know that this would be something different. Once they realised how different this was, then there was a real interest and a real significant, but I think the interest was mainly in compassionate neighbours signing up, and then the community members are often referred in by others, so like GPs. So we were trying to push more people referring themselves in. And in fact, one of the new projects is in a sheltered housing area where you've got a community of people living in one house, but they were relatively separate. And so some of the compassionate neighbours has gone in to start building relationships with everyone in there. And people then could come and join the kind of the social group if they wanted to. So kind of putting the onus, rather than being referred in by someone you may or might know, you're choosing to join something. And again, that comes back to that agency, that if you can actually put it in people's own power to decide if they want this, then the outcomes are going to be much more significant than if you're kind of referred in, your GP's referred you in, you're kind of given community some form of support. You know, the agency isn't there. So I think it's really, really difficult to give agency to people who might bedbound at home, you know, by themselves. But any way that allows that is going to really improve the impact of the work. We probably need to stop, don't we now? We've gone over.
Yeah, so that's the extent of the questions that were posted. I just put a quick question and see if there are any other ones, but it doesn't seem.
I can pick some of these up as well. If people want to email me, I'm really, really happy. I'll put my email on here. If there's anything that we didn't get to speak about that was important.
Yeah, and just to remind everybody, if you're a member, the link to the video and the PowerPoint will be in the member section. If you're not, I will email that out to you like I did for the first webinar. And you can also access the first webinar with Julie and Abel in the same members section as well.
Thanks so much for coming, everyone. I've really enjoyed it. I feel like it's a bit kind of alien. I want to talk to you all, so it's a shame everyone's muted. It's a bit weird being kind of, you know, not able to get any feedback, but I hope that was helpful. I'm really happy if I can be at all helpful in any way, just email me. And yeah, we can continue the conversation.
Great, thank you, Libby. I know, again, this is always a tough one to attack, but I think you gave us some great starting points. And yeah, you can reach out to Libby. She posted her email, as well as if you're having any issues, you all have my email, so don't be afraid to send me an email, and I will try and help whatever issue you have. All right.
Look forward to the next one.
Yes, the next one will probably be in February, March. We're just sussing out a great webinar presenter right now. All right, everybody, have a great day, and thank you for participating.